Hello everyone, my name is Dr. Judy Dukeshire and I'm going to do a voiceover for the preceptor mentorship slides that concern the nurse residents in the CASN nurse residency program. And I wanted to start by saying thank you so much for committing the time and the energy. Preceptorship and mentorship are very active events in the life of a nurse resident, and there is no question in my mind, based on the research so far, that the impact of your relationship with that NR is critical. So what we're going to be talking about today is just a sense of the overview of the program for nurse residents. What are your roles and responsibilities as preceptors and mentors, and how are we evaluating the program? It's very important that you understand that your role in this program cannot be overstated. And Health Canada will receive a report at the end of the 4-year pilot. And in that report will be all of our findings from the nurse residents, preceptor mentors, all the instruments that we've used for the research, and any comments from managers, site coordinators, and outside educators. So I'm going to talk a little bit about that in these slides. So as you all know, you are involved in a nurse residency program for newly graduated nurses in Canada. It is a national program. So that is in part what's so fascinating, is getting information from residents in different programs, in different institutions throughout the country. So the support, as you also understand at this point, it goes from 0 to 6 months. And the initial 3 months, of course, are intended to be very hands-on, alongside, side by side, as a matter of fact, on every shift, with a shared workload between the PM and the NR. We intend through this program to help these newly graduated nurses transition in a healthy and effective manner. We want them to be strong members of the nursing team, and we hope by that we will increase their interest in staying a part of your institution and nursing in general. So the residency program uses strong theoretical foundations to build the nursing capacity and competence by offering structured and very intentional supports for the nurse residents. The relationship of the preceptor mentor to the nurse resident in this residency program cannot be overstated. You are an expert clinician. You are being trained in new graduate transition and the challenges that these new nurses face graduating today, as opposed to graduating perhaps when you did or earlier. The interesting thing about the preceptor mentorship role is that a lot of people don't understand that it is an active role. So it is not sitting back and waiting for the graduate to come to you. It's planning sessions with them on several times during the course of the day, perhaps before a task and after a task, so you can pre-brief and debrief. And so that's what we're going to be talking about a little bit today, is this idea of it being an active role in advancing the practice, judgment, and decision making of the nurse residents through pre- and debriefing sessions throughout their residency program. I'm not sure that you appreciate how much your experience and your championing of these nurse residents matters to their success. But there is absolutely no doubt in my mind, as the primary investigator in this research, and having done research in the area of new graduate transition for 28 years, I can guarantee you that the most important role for them in this initial 6 months is you. And so I just wanted you to really understand that. that this is an active experience. They learn to trust and they learn to model their practice after you. So that's why it's so important that what you're doing is intentional. And so when you start out with the nurse residents, we're going to talk a little bit about the kinds of questions that you can ask them. For instance, how are you progressing today? How are things better today or worse today than they were yesterday or last week? And as you talk with them, I want you to think about, how can I prompt them with questions that make them think about their practice? Think about why they're doing what they're doing. In this particular situation, what would be different in the way you approach this particular task? For instance, because of the context, this patient, their family, where they come from, what challenges they're having, and what does that NR need to advance their practice today? And you'll ask yourself that question every day. So just to review, week 1 is their site orientation. And you probably won't have much to do with them, if anything, during that orientation phase, simply because they are in hospital and unit orientation and they're not actually caring for patients. Starting on week 2 is when they move into the transition phase, and this is where you are working shoulder to shoulder with them, increasingly progressing their work. So they start slow, and I always recommend that you start them with one patient. Let them do everything for that one patient. So it might be that, you're fielding calls or whatever for the first day, but by the time they're done the second or third day of your initial contact with them, they should be doing everything for that one patient. So they're talking to the doctor, they're organizing allied health responsibilities, they're taking phone calls, they're being interrupted just like they would be interrupted in a normal situation, except it's only one patient. So they learn how to navigate the time management. Time management is very difficult for a new grad. And oftentimes what preceptor mentors will do is they will give them, several patients, but then they'll follow them around and they'll notice that they have to pick this up and they have to pick that up, and I'll answer the phone calls for you, and a doc came into the unit, so I'll talk with him. And in the meantime, the nurse resident or the new graduate is thinking that they're doing everything for these patients. And when they get more patients and then people back away from helping them out and rescuing them as needed, they're overwhelmed because they never did take full responsibility for all of the experiences that are required of them as a clinician. So my recommendation is start with one and make sure that they are completely independent with that one patient doing everything. And it's hard when you're a preceptor mentor because you see that they're struggling and you want to help them. But I think the difficulty with assisting them without them knowing you're assisting them is that they become quite surprised to find out later that that's something that was their responsibility. So if you are going to answer a phone or take a phone call from a physician or an allied health professional for them, you need to ask them, I'm going to take a phone call for you, or I took a phone call for you today, but I'm not going to do that tomorrow. So that they're prepared that they may be called in the middle of something to take a call. They're going to have to make a decision about how they respond to that. These are all very nuanced pieces of the transition that sometimes PMs, that's you, don't always think about or consider because they just want to help the graduate. But just think maybe a little bit about, is that really being helpful for them? Within that transition phase, so this is the first 3 months, they are going to do 4 virtual simulations, and it's helpful if you can make note of that and just check with them to find out if they've done them. Sometimes they get overwhelmed as they move from 1 patient to 2 patients to 3 patients in that initial 3 months. And I wouldn't go speedily through that. I would make sure they're really coping well with the load that they have. And as I had mentioned, doing everything before you add another patient. And then once you've added the patients, you can start thinking about, okay, they're managing all the patients that they'll need to manage. Maybe we add a little bit of complexity in here. So we take an unstable patient and give them an unstable patient along with their other patients. Because by now, they have gotten up to speed on their time management, and they can probably afford for something to go off kilter. Initially, for a new graduate, things that go off kilter, patients who go south, additional calls that they weren't expecting, having to deal with allied health and family, that's all sort of outside of their focus on the patient. And as hard as it is to remember, we're all like this when we first start, and it's challenging for them. So just a reminder to take it slow. No need to feel like they need to be up to speed within the first couple of weeks. I would expect that by the time they are at a month, they are taking a full load of patients, and then the next while would be increasing the complexity and the instability and the inconsistency and the lack of predictability. Those are all pieces that should come after they have managed very well for at least a couple of weeks with their full patient load doing everything. Also, there are workshops. There's 4 workshops in the transition phase and 2 workshops in the integration phase, so the 3 to 6 month period. And I'm hearing that these workshops are really important to them because they allow them an opportunity to leave the clinical area, be in a safe environment with people going through exactly what they're going through, and they talk about how they applied their knowledge. They listen to the way other nurse residents are applying their knowledge and the experiences that they're having. So those workshops are really critical for them to understand the progression of their transition. So once again, if you can, keep in your mind that they are going to be needing to attend 4 workshops during that 3 to 6 months, that should be a part of their workload. But if you can, flag them on it and say, hey, have you done this? Have you attended your workshops? Have you listened and looked at your virtual simulations? And the final thing that I want you as PMs to remember in terms of the evaluation is that you need to do your competency rubric evaluation at 3 months and then at 6 months. So the 3-month one is where you fill it out, and if you're not sure about that, you should have received information from the research coordinator, Catherine Corneau. And she'd send you access to the competency rubric. And you basically fill it out first. So this is your assessment of how that individual is doing. And then you sit down with the nurse resident and show them the way that you think, or however you think that you want to do it. Maybe you want them to fill out the entire evaluation, so you want to make 2 copies, one you do and one they do, and then you compare them. Or you can show them, what you have assessed them to be at in terms of their competency, and you have a discussion about that and agree on that ultimate competency rubric, and then that is submitted to the research program for evaluation as a whole. And the same thing at 6 months. So the integration phase from 3 to 6 months, it's been fascinating for me to see how important that 3 to 6 months is, that they still have contact with you. They feel so, safe and comfortable asking questions, and they know that you are still there for them between 3 to 6 months. And that seems to be enough of a buffer to pull them all the way out to 6 months, where they are then very confident and ready to be on their own. So I think that last 3 months, from 3 to 6 months for the nurse resident, is more important than I imagine you think it is. So I'm excited that you're going to spend that second 3 months with them. They will have assumed a full patient load by then, and I know that that's part of the residency program. So now you have a workload and they have a workload. And just knowing, though, that you're checking in on them to see how they're doing, and they can ask you for advice and they can run some decisions by you, that's super, super helpful for them. And then they have 2 workshops through CASN. So again, you might want to just keep those in mind and say, hey, when are you attending those workshops you're supposed to be going to? So I'm going to talk about each of these phases. So the initial transition phase, which is week 2, because of course week 1 is their hospital orientation. Week 2 is where you just sort of establish your relationship. So during that week, I'm hoping that you can, give them any orientation you feel that they need from you, talking to them about their previous experiences, maybe jobs that they've had, and how they anticipate what's going to happen in their transition. What are they anxious about? What is it that they need from you, that they think they need from you? And my suggestion is that you talk about your transition to practice. And that sort of vulnerability, knowing that you went through a transition as well, and maybe sharing some silly, crazy, fun stories, will make them feel a little bit less alone. Sharing your experience as a nurse, and telling them a little bit about why you chose to be where you are right now and how that's progressed for you. And maybe talk a little bit about how you're going to approach the preceptoring. Ask them what motivates and encourages them, and then you're going to set clear expectations for each week, 1 week at a time, because depending on how things go that week, you'll know how to progress them into the second week. So I want you to establish a time to debrief with them twice a day for the first month, because by the time the first month is through, if you are debriefing like this and doing it intentionally, and I'm going to share a bunch of questions and ideas that you can use in enacting your preceptorship, they will definitely be ready by 4 weeks to 6 weeks to start taking more complex patients. So during your initial week together, so week 1 was their hospital orientation. As you can see now, week 2, they're starting with you. And week 2 should be not overly intense. Just try to welcome them to the unit. Talk a lot about the challenges that they're going to encounter as a nurse resident. Maybe ask them what they think they're most concerned about. Ask them perhaps how they cope with stress, so that you have a sense if they're withdrawing that, oh yeah, they said that's how they cope with stress, or they get hyper, or they stay quiet, or something like that. And then talk together about an approach that you can use to pre-brief and debrief on the practice activities over the course of your shift. So you're sharing the workload for the first 3 months, and I suggest that you start really slow with that. So again, this week, maybe they could perform some of the skills that they'll need to do really well. And I recommend this to all nurse residents. Is for at least the first week, they literally stand in huddle and say, I'm starting all the IVs today. If anybody has an IV, I'm your person. And find a way that staff can communicate that to you, whether they write it on a board or they write it on a clip note or something like that. Or they use the communication system to let you know that there's an IV start in 5B whenever you get a chance, kind of thing. So the skills are helpful for them because they know that people are watching them perform their skills. And if they screw up on a skill, it really sets them back. And it takes so much energy for them to sort of focus on that skill so they do it right, that if they can get that out of the way in the first week that you're with them, it's going to be really beneficial for them down the road when they have to start thinking about decision making and clinical judgment, and they can't focus as solely on the tasks that they're supposed to perform. So have a discussion about what are the 5 things that you need to do well in this unit, and you need to do them frequently, and then get them experience in those things for that first week. It also endears them to the other staff, and you know, when you are in huddle, if you can explain, this is a nurse resident, this is a fully accountable, registered nurse who is working on our unit now, and they're in the nurse residency program for CASN. And here's what the program entails, and here's what you're going to see us doing. And so for this week, the nurse resident's going to be doing a lot of the skills that we do on the unit. So if you can help us out in general by saying, hey, I've got something you could look at here, or hey, I've got a dressing to do, or an IV to start, or whatever, that would be very helpful for them. So now that week 2 is done, and hopefully your resident is feeling more comfortable with you, you've talked a little bit about the patients that you're caring for, because you'll probably be caring for all of the patients. And you can talk about, this is why in the morning, this is why I've set my day out like this. This is why I'm prioritizing this patient. This is why I changed once I saw the patient, is because things look different. And now I've got this other patient who's sicker, so I'm going to reorganize my schedule. So that's all happening in week 2. So week 2 is very intensive. It's just not a lot of responsibility immediately for the nurse resident, and they can get a little bit more comfortable with the routines and the tasks. Week 3 is when you will start planning the NR's progression. So my suggestion, as I've mentioned before, is to initially assign them 1 to 2 patients that are stable and predictable, as much as you can in the context of acute care these days. Over the 3-month period, they'll expand to a greater number of patients. And once they're at the highest number that they'll need to care for by themselves, and they're managing the time, and they're dealing with the odd thing that goes wrong, that sort of thing, they're talking to physicians and allied health, etc., then it's time, and I would imagine this is at around 2 months, that you're going to start giving them less predictable patients, more complex patients, and it might just be that the family is a challenge to deal with. That might be a complexity that they would need to navigate, and would likely be better off to do that later rather than earlier in that 3 months. So the evolution of expectations of their care need to be very carefully orchestrated, and that's why I always say your PM role is a very active one. It's not a passive role where you say, okay, this is yours, let me know if you have questions. Well, that's not helpful for a new resident or a new graduate, because they don't know what questions to ask. So I think, pre-briefing and debriefing is really important to draw out some of the challenges that they're having, and your ability to simply observe. Watch them do what they're doing, and then when you debrief, you can say, I noticed this. I just thought I'd offer some ideas that I had on how you might have coped with that differently, that sort of thing. So again, your role isn't just to orientate them to the unit and to be there if they have questions, but rather to actively support their transition. And in order to do that, you need to understand what that transition is like. You need to understand what the first stage of transition is like. And that is also in your PM training. So if you have any questions, by all means, reach out to Nursing the Future, which is a nonprofit organization that talks all about transition and how to support newly graduated nurses. Again, that's Nursing the Future. And if you just Google it, it'll come up for you. So understanding what they're going through in that initial period, which will include transition shock, will help you, because transition shock can be very disorientating. And so if you know what it is and how it might be expressed by your NR, you'll be much better off. And I've included a link in there that will help you understand transition shock and that first stage of transition. So during that initial 3 months, you want to debrief with them at least a couple times a day. And then at about a month, you can go to once a day. Or if you want to continue the rhythm of twice a day, that would be fantastic if you have time to do that. So the questions for debriefing in that 3 to 14 weeks, which is that first 3 months, things like how can we scaffold your learning? And you would revisit this each week. So what can we do to increase your learning a little bit more this week, but not overwhelm you? That's what's going to help them make more independent decisions if you're reviewing their thinking with them. Questions like, what discrepancies have you noticed about what you thought nursing was going to be and what it is? And how can, I say we, but in many ways I mean you, how can you help them adjust to those differences? What was it like for you? How were you able to manage the stress? How do you find work-life balance? How do you deal with unruly families? What do you do when a patient starts to flirt with you? Like all of these things that nobody talks about in school, and you've likely had those experiences. You can talk to them about those experiences, and that is what really cements the trust that the nurse resident has in their relationship with you. You do want to get a sense of their confidence, and is it increasing? And if not, what's stopping that from occurring? They may feel reticent to tell you because they want you to be impressed by them. So that's why sandwiching, I know you've probably heard of this approach oftentimes, and that is to start out with, I just wanted you to know how much I really appreciated the way you interacted with that patient today. You were so caring, and you were very thoughtful, and you didn't impose anything on them. How did you feel when they responded to you with that kind of, they seemed a bit angry? What did you think was going on for them then? That's how you can draw into, well, this is how I might have dealt differently with their anger than you did. And that's where that learning comes in, right? So if their confidence is increasing, that's great. You can start to push them a little bit more. How can we grow your confidence more than it is now? And then if they don't appear to be confident, digging into that a little bit is always helpful initially within that first month. Although they're not going to have a lot of confidence until probably the end of their second month. So don't necessarily expect them to feel confident until at least 2 months. And I think what's interesting is to notice what questions they're asking. And you can even say to them, I want you to ask me at least 2 questions during our debrief. And that prepares them for what you want out of that debrief. And the questions will illuminate for you the kinds of challenges that they're having. Either questions are deep or the questions are superficial. And what are you noticing about the change in the way they're asking questions? Are they getting deeper, or are they still asking basically the same question? And if so, what is preventing them from learning what they need to learn to have that answer embedded in their minds? Same with the skill competence. How are they feeling about their skills? I certainly hear a lot of units where the nurses will just pull the resident in and say, hey, I've got something I need you to see. And if that can happen and you can encourage that with other nurses, it's always helpful. Having you as that primary person to go to is very important, because that's where the trust comes in. But being able to see a whole bunch of different situations is also very helpful. And then you can always end each week with, how did we increase the challenges to your practice? And how did you manage those challenges? And what do you want to do next week? How do you want to be challenged more next week? What do we still need to work on? So those are questions for this initial 3-month period. The third phase is what we call the integration phase. And this is where everything should start to basically come together. This is probably going to be after you're side-by-side with them. Things don't usually completely come together for the new graduate until about 5 months. So there's going to be a couple months in there where you let them go into that independent role, but they're not quite ready. They're ready to go, but they're not going to feel that way necessarily. So your contact with them, particularly at about 4 to 5 months on every shift, just checking in with them to see how they're doing. How's it going today? You know, it doesn't have to be long, it doesn't have to be intensive, but just letting them know, hey, I'm here. If you have any questions, just come get me. That sense of security, knowing they're not alone, gives them this real sense of liberation. So they can take a few more risks because they know you're there. And I think they just feel better knowing that someone is open to their questions and will stop what they're doing to help them if they need it. So obviously, as you know, at this point, they're taking a full patient assignment. They're likely less tied to you, but the initial, I'd say, 2 weeks to even a month after they've separated from you side by side is going to be stressful for them. So the more you can kind of connect with them over the course of the day, maybe have lunch together and say, how are things going? And start to ensure that their questions are being answered by themselves. So, well, did you look at any web resources to figure out the answer? So if they come to you with questions, your response is not to answer the question. Your response is to turn the question back to them and say, how can you figure this answer out? What is it that you need and where can you get it? That would be very helpful for them. So now they're going to be moving into the second stage of their transition, which, as you know, is the being stage, where they're starting to consolidate. They're becoming this professional practitioner that's responsible for their decisions, judgments, and actions. And they're going to start feeling that way as well. They can practice the way they would like to practice. They're not accountable to anybody except themselves. And so they're going to start to test out some of those boundaries. And they might do things differently than you do, but that's kind of important for them to develop an individuation of who they are as a practitioner. As a PM, you can provide clarification and confirmation on their thoughts and processes and give them emotional support as needed. Those are the most important things during this second phase of their, or the third phase, the integration phase of their experience of transition. So as we've done with the other phases of their transition, in the integration phase, so that second 3 months, they're going to start putting things together for the most part. And as they start to put things together, they remember things they saw, they've started to make decisions or come to conclusions about their colleagues, the practice that they're seeing on the unit. And so the focus in the second 3 months, as they move into that second stage of reflecting on what nursing is, the kind of practice they want to perform as a nurse, what they're seeing around them, they'll start to challenge the practices that they're seeing around them. So it's good for them to have someone to talk to about poor practice that they're seeing in their colleagues. It's good for them to be able to come to you with difficult clinical situations, how they dealt with them, and perhaps you can share your experiences on how you might have dealt with it had that been you. There is also this, this overriding sense that I might not be able to practice the way I was taught to practice. And this is a very tenuous time for the new graduate, because they may adopt practices because of what they've seen around them that cause them to compromise their standards, because they think, well, everybody does that here, which isn't a good practice. Obviously, we all got to try to maintain our ethics and our standards of practice. So you might want to start exploring with them whether or not there are situations in which they felt they couldn't practice the way that they were taught or the way that they want to practice. For instance, I can't spend enough time with the patients. Okay, how can you make the time that you do spend with the patients really impactful? Is there a different approach you can use? Can you organize yourself a bit differently so that you have time? Instead of sitting at the nurse's station, why don't you take that half an hour and go back to one of the patient's rooms and just open up a conversation with them? So there are ways that you can talk to them about this. And share, once again, your expertise, because that's why you're in this position, is that you are a clinical, relational, professional practice expert. So the other thing that they often experience at this point is they're noticing relational issues that they have with individuals. They might feel bullied by certain people. And this is where it's important that you understand how you approach conflict in the workplace and help them to deal with these bullying situations or people that are just challenging in general. How do you approach that with a neutrality that is imbued with some confidence? And this is what they need from you. They actually need role playing. Well, this is what I might have said. Let's go through an example. Okay, I'm Janice, and you're going to ask me a question. So go ahead and ask me a question. So you can go through this with them and respond in a role-playing way of things you might do and ways you might respond. And then what doubts are they experiencing? Because they will be. They might be even wondering if this is the profession for them. And that's something that they need to talk about. And the more that you're able to open that conversation, the better off they'll be. And you can say to them, it's not at all uncommon for new nurses to question why they came into the profession, and they see things are different in practice than they were when they were students, and they struggle with that. Are you struggling with any of those things? Because it normalizes it for them, and they're much more likely to share their experiences if they think they're not the only one having them. And then you can explore, well, let's just see why you feel unsure and insecure about that, because you've done quite a few IVs. So why do you still feel unsure about them? And sort of digging into the issues with questions that allow them to be transparent about what's underneath all of what they're feeling. And then, of course, understanding how they can take care of themselves. For instance, being called in on overtime. That's something that's always stressful. I know that it was stressful for me, and it's something that every nurse has to figure out a way to deal with. And these days it's a bit easier because you just don't even have to answer the messages, but sometimes your staff will call you and they're desperate. So how do you help them manage that work-life balance, and how can they start to engage in their personal life again? Because that's what this second stage is going to be all about. So now that we've talked about your relationship and possibly some of your approach to being a PM for this nurse resident, just a reminder that their competency is part of the expectation of the nurse residency program. And so we look at a variety of roles that they assume. They're knowledge workers, so they have evidence-informed approaches to their care. They actually care and do the tasks that they need to do. They communicate and collaborate with other healthcare professionals and other nurses. And they're a force of change in the unit, in the institution, at the patient level, within the family, as all nurses are. So the competencies will be based on those particular components. This is an example of the difference that you can expect between a grad at 3 months and a grad at 6 months. And this is offered in the competency framework document. But there are different indicators that will tell you that they've reached where they need to be. And you can see that the depth and the synthesis of information is different from 3 months to 6 months. So maybe go take a look at those, and that will help you understand how they should have progressed from the first competency assessment to the second. Just a note on the competency framework that we added a category called unable to assess. And the unable to assess may be because you never saw them do it, they never had an opportunity to even practice that particular skill. And the comment section is generally for partially met, unmet, or unable to assess, just so that we can catalog the reasons why they may not have met a particular indicator. And that's just part of the research for us. I'm sure you know this already, but the metrics, or those elements that we are actually measuring with the newly graduated nurses, have to do with their experience of transition shock in those initial weeks and initial months, and then the initial stages, so that's stage 1 and stage 2 of transition, and how they're managing all of the aspects of the challenges to transitioning that are common for new graduates. We're looking at their stress response. So how stressed are they? How do they cope with stress? Has that stress changed over time? Integration into the workforce is all about how comfortable they feel with their colleagues, how much they feel like they're a member of a team. And then competency development and workload capacity is just their ability to manage the roles and responsibilities, to navigate the time challenges that they have, to get all their work done over the course of a shift, and to continue to grow and develop in their competencies. So the findings will ultimately be reported on and offered to your institution and to Health Canada, and they will come through as an entire group finding, and that's just to ensure the confidentiality of all of the participants. These next 2 slides just give you a sense at a glance of all the different research components that the NRs go through, and then what you would go through as well. So this is the nurse resident map, where you can see in that initial program intake and orientation, they sign a consent form, they fill out an information form, they attend a virtual introduction, and that would have been by me, and they begin their weekly program checklists. And those are the operational fidelity checklists that they get by text, and they just literally go on the link, and they should be able to sit down in the unit and do all of these things as part of their initial 3 months. And it's a very quick checklist that they do. The second section of data collection is weekly and bi-weekly program checklists, again, that they'll get emails and texts about. They'll do an interview at 3 months and then an interview at 6 months. They do the competency rubric evaluation with you, and of course, as I mentioned before, you do it first, and you may get them to do a separate one, and then you compare them, but you ultimately come to a negotiated conclusion on their competency. And again, it's the competency at 3 months. It's not that they need to be at 6 months. They just need to be at that 3-month competency level. And then you can see the remaining data collection points in that nurse residence tenure. So this is your preceptor mentor data collection. Obviously, you are required to fill out a consent form as well, which I hope you've done, and I hope you want to be part of the research. We are truly fortunate to have 4 years of supplemented nurse residency training, and we're equally appreciative that your institution has offered you and the nurse resident an opportunity to seriously make changes in the transition experience of new graduates throughout Canada. So once you've done your information form, you will also be encouraged to attend the introductory session that I have with the nurse residents. And I hope you do, because it's an opportunity for you to hear what I say to them and for us to meet, which is wonderful. At 3 months, so the only expectations from a research perspective for you are at 3 months, there is a competency rubric that you need to do, and I know I've mentioned that a couple of times. And then at 6 months, I'm going to send out an invitation for you to participate in either a focus group or an interview with me on how the resident has done. How did the program go for you? Were there things you needed but you didn't have? What did you enjoy most about being a PM in this program? And then, of course, finishing the 6-month competency rubric evaluation with your NR. So thanks for listening. I hope that this slide presentation offered you a little bit of a window into some of the expectations of the PM role within the nurse residency program. And I just wanted to say again, thank you so much, because your role in this residency program for that nurse resident is pivotal. I wish you well, and don't hesitate to reach out to the research coordinator or myself or CASN if you have any questions along the way.